Let's jump straight into the diagnostic workflow of beta thalassemia. We're going to track the blood from the HBB gene mutation all the way down to the clinical phenotype. We'll break down exactly how molecular genetics dictate the laboratory patterns you're seeing right in front of you and how we actually translate those findings into modern clinical management. To structure our analysis in this explainer, we're going to map this genotype to phenotype journey across 6 critical stages: molecular genetics and fetal switching, the heterozygous carrier state, modifiers and variant combinations, TDT versus NTDT classifications, iron overload and complications, and finally, modern and curative therapies. Let's get to it. Starting off with Section 1, molecular genetics and fetal switching. We really have to begin at chromosome 11p15.4 to understand the fundamental genetic mechanics here. So here's a classic examiner trap for you. Why does severe beta thalassemia only appear after the first few months of life? I mean, a newborn with severe beta thal major looks perfectly healthy at birth, right? Well, the answer lies entirely in the mechanics of normal hemoglobin switching. Think about it. During fetal life, the predominant hemoglobin is HbF, which is driven by gamma chains. But watch this timeline closely. Right around birth, gamma chain expression naturally plummets, and beta chain expression starts ramping up to create adult hemoglobin A. So infants with beta thalassemia, they're actually protected by fetal hemoglobin. It's like a temporary shield. That shield stays up until those gamma chains drop. Right around 6 to 12 months of age, the defective beta chains are suddenly called upon, and bam! The devastating effects of the globin imbalance begin. Now, your primary task at the bench is determining the actual nature of the beta-globin defect. You have to ask, does the patient have a beta-0 allele, meaning producing literally 0 functional beta-globin because of a nonsense or frameshift variant? Or do they have a beta-plus allele, which produces a reduced output due to promoter or partial splice defects? Determining if it's a complete absence or just a reduction of beta chains is absolutely crucial. Why? Because it completely dictates the severity of the ensuing unmatched alpha chain excess. Moving right along to Section 2, the heterozygous carrier state. Let's look at how these traits manifest on a routine CBC. When you're evaluating a routine CBC, you absolutely must contrast beta thalassemia trait with something we see every day: iron deficiency anemia. If you're looking at marked microcytosis, so a very low MCV, but it's paired with a paradoxically high red blood cell count and a normal ferritin level, you've got to think thalassemia trait before iron deficiency. And check out the RDW. It's often totally normal in the trait, which is a stark contrast to the wide variation we typically see in iron deficiency. To actually confirm that trait, we're looking for the biochemical hallmark: a hemoglobin A2 fraction greater than or equal to 3.5%. This is your classic diagnostic threshold. We typically quantify this using cation exchange HPLC, where we're looking at where the HB elutes based on charge interactions, or capillary zone electrophoresis, where electrophoretic mobility is key. Just remember, though, always apply the specific reference ranges for your labs method. But hey, do not fall into the trap of ruling out beta thal trait just because the HbA₂ comes back normal. There are so many confounders. Coexisting iron deficiency can artificially lower the HbA₂ fraction, giving you a false negative. On top of that, things like coexisting delta thalassemia, severe alpha thalassemia, or a clinically silent beta thalassemia allele, or even KLF1 variants, can easily obscure your diagnosis. The golden rule here? Always correct iron deficiency first before finalizing your hemoglobin analysis. Okay, Section 3, modifiers and variant combinations. Let's dive into why 2 patients with the exact same primary mutation can look so clinically different. And this brings us to a massive, overarching principle of hemoglobinopathy diagnosis. The exact same HBB genotype does not equal the same clinical phenotype. Never assume you know the clinical picture just from the primary beta-globin mutation alone. Disease severity is heavily modulated by secondary genetic modifiers, specifically alpha chain dosage and HbF promoters. Let's look at alpha chain modifiers for a second. The cellular damage in beta thalassemia is literally caused by the toxic excess of unmatched alpha chains. So paradoxically, if a patient co-inherits alpha thalassemia, it actually rescues the phenotype. It reduces that free alpha chain excess and improves the balance, giving you milder anemia. On the flip side, inheriting an alpha globin triplication accelerates the damage. It worsens that globin imbalance and can turn what would be a mild trait into a severe thalassemia intermedia.
You also need to keep an eagle eye out for structural variant combinations. For instance, HbE acts as a mild thalassemic allele itself, making HbE/β0 thalassemia a highly variable and critical compound syndrome. Then you have HbS/β0, where there's no true HbA, and the phenotype basically mimics sickle cell anemia. Oh, and don't forget HbLaPour. That's a delta beta fusion that makes laboratory interpretation a real headache because it mimics an abnormal peak in the HbA₂ region. And finally, deletional hereditary persistence of fetal hemoglobin, or HPFH. This strongly ameliorates beta thalassemia by maintaining high, protective, pancellular levels of HbF. Moving on to Section 4, TDT versus NTDT classifications. Rather than relying on outdated terms like major, intermediate, and minor, modern hematology stratifies patients by their actual transfusion requirements. Transfusion-dependent thalassemia, or TDT, means the patient requires lifelong regular red cell transfusions just to survive and to suppress massive ineffective erythropoiesis. Now, non-transfusion-dependent thalassemia, or NTDT, simply means the patient doesn't routinely require survival transfusions. But let me be clear, NTDT is not a mild disease. These patients still face massive risks from hypercoagulability, untreated marrow expansion, and severe iron toxicity from gut absorption. For our TDT patients, 9 to 10.5 grams per deciliter is the strict pre-transfusion hemoglobin target. Listen, we aren't just transfusing to treat anemia symptoms here. We're transfusing to physically shut down that hyperactive bone marrow. Maintaining this exact hemoglobin level is absolutely necessary to prevent severe, bone-deforming skeletal changes, like frontal bossing. Which naturally leads us to Section 5, iron overload and complications. So you might be wondering, how does an NTDT patient who rarely, if ever, gets a blood transfusion end up with lethal organ iron overload? Well, the culprit is erythroferrone. This is a hormone produced by the expanded, hyperactive bone marrow, and it completely suppresses hepcidin. Without hepcidin putting the brakes on things, the intestines just absorb iron uncontrollably. Over time, this leads to devastating, organ-damaging iron overload. To combat this massive iron influx across both classifications, we rely on heavy-hitting chelation agents. Deferoxamine has a long history of removing hepatic and cardiac iron, but it's given sub-Q or IV, so it really suffers from poor patient adherence. Then there's oral deferoprone. It's incredibly powerful at clearing cardiac iron, but it carries a strict warning. It requires mandatory neutrophil monitoring because of the risk of agranulocytosis. Finally, deferoxamine is an oral, once-daily option with excellent systemic reduction, though it needs renal and hepatic monitoring. To balance all this, cardiac T2-star MRI is essential. It lets us estimate myocardial iron so we can precisely guide our chelation intensity. Finally, let's wrap up with Section 6. Modern and curative therapies. Beyond traditional transfusions, we now have therapies that target the red cell life cycle directly. It's a real game changer. Luspatercept acts as a ligand trap. It actually promotes late-stage red cell maturation to reduce the overall transfusion burden. Then we have mitapivat, which is an FDA-approved oral pyruvate kinase activator. It essentially cranks up ATP production to help those fragile red cells survive longer. And of course, classic hydroxyurea is still used to coax the body into making more fetal hemoglobin in selected patients, though the response there can be highly variable. But let's talk about the absolute elegance of CRISPR therapy, specifically exogamoglogen autotemcel. The process is revolutionary. First, we harvest the patient's autologous CD34-positive stem cells. Next, we use CRISPR editing to disrupt the BCL11A erythroid enhancer. Because BCL11A is the repressor that normally turns off fetal hemoglobin after birth, editing it basically removes the brakes. After administering myeloablative conditioning to the patient, we reinfuse those edited cells. They start pumping out HbF, which perfectly bind up those toxic free alpha chains, functionally curing the globin imbalance. Incredible, right? But as we celebrate cures for severe disease, we literally cannot forget our NTDT patients. Avoiding the transfusion chair does not mean avoiding the disease. NTDT patients require rigorous, lifelong, multidisciplinary surveillance for silent threats like hypercoagulability, pulmonary hypertension, and progressive organ damage. Active surveillance is simply mandatory. Which brings us to the future of diagnostics and a final thought to leave you with. Currently, routine newborn screening really struggles to flag beta thalassemia traits because, as we discussed, HbA₂ just isn't useful at birth. But as genetic sequencing becomes faster and therapies get more precise, we have to ask, are the days of relying solely on borderline HbA₂ fractions and complex HPLC patterns finally numbered? Will targeted, universal HBB genetic sequencing soon become our definitive baseline standard? It's a profound question as the landscape of hematology evolves, and definitely something to watch closely.